Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we are going to discuss about very commonly used class of agents in ICU, that is sedative agents. So Maddie, can you please describe the pharmacological properties of an ideal agent for sedating patients in ICU?
Sure. So the pharmacological properties can be subdivided into pharmaceutical, pharmacokinetic, and pharmacodynamic properties. The pharmaceutical properties include being water soluble and stable in solution, having a long shelf life, being stable on exposure to light, having no pain on intravenous injection, being cheap, bacteriostatic, compatible with other medications and solutions, and the presence of a reversal agent or antagonist. Pharmacokinetic properties include having a rapid onset, a low volume of distribution, rapid clearance and metabolism, clearance which is not affected by renal or hepatic impairment, no active metabolites, no interaction with neuromuscular blocking agents, and minimal individual variation in pharmacokinetics. And finally, the pharmacodynamic properties of an ideal agent include having a high therapeutic ratio, solely affecting the central nervous system, having analgesic properties, possessing minimal cardiovascular or respiratory depression, causing no histamine release or hypersensitivity reactions, being antiemetic, having no emergence nightmares, and no tachyphylaxis.
Okay, so very commonly used sedative agent in ICU is propofol. Can you please outline its pharmacology?
Propofol is an intravenous sedative and anesthetic agent which is commonly used in ICU as an induction agent in intubation and as an infusion in mechanically ventilated patients. Its pharmacology can be thought of in terms of its pharmaceutics, pharmacokinetics, and pharmacodynamics. In terms of its pharmaceutics, propofol is presented as a 1% or 2% lipid water emulsion containing soybean oil and egg lecithin. It has a characteristic white, milky appearance, making it easily identifiable and is available in vials of 20, 50, and 100 mils. In terms of pharmacokinetics, this can be divided into administration, distribution, metabolism, and elimination. Administration. Propofol is given intravenously at a dose of 2 to 2.5 milligrams per kilogram for induction of anesthesia. It has a rapid onset of action of approximately 30 seconds and a duration of 3 to 10 minutes, making it easily titratable. It is painful on intravenous injection. Distribution. Propofol is highly lipophilic with a volume of distribution of 2 to 10 liters per kilogram. It is highly protein bound at 97%. Propofol follows a 3-compartment pharmacokinetic model: plasma, rapidly equilibrating tissues, and slowly equilibrating tissues. This means that after a bolus of propofol, there is rapid equilibration between the plasma and the brain, which is highly perfused, resulting in a quick anesthetic effect. Despite its rapid tissue distribution and large volume of distribution, propofol has a short context-sensitive half-time of 20 minutes after prolonged infusions, making it very useful as an infusion in ICU. Metabolism. Propofol is metabolized mainly in the liver into glucuronide conjugates and sulfate. These are inactive metabolites. Clearance of propofol exceeds hepatic blood flow, suggesting there are some extrahepatic sites of metabolism. Elimination. Propofol has an initial distribution half-life of 2 to 4 minutes, rapid elimination half-life of 30 to 60 minutes, and a slower elimination half-life of 3 to 9 hours. It is 88% renally eliminated as metabolites, and moderate hepatic or renal impairment does not alter its pharmacokinetics. In terms of its pharmacodynamics, propofol is postulated to act by enhancing inhibitory synaptic transmission through activation of the chloride channel on GABA A receptors. GABA is the main inhibitory neurotransmitter in the central nervous system. Propofol has several effects which can be classified based on system. Cardiovascular effects include decreased systemic vascular resistance, negative inotropy, and decreased sympathetic activity, all of which can result in hypotension and bradycardia. Respiratory effects include respiratory depression, apnea, and loss of airway reflexes, making it useful as an induction agent. It can also cause bronchodilation. Gastrointestinal effects include anti-emesis and hyperlipidemia. Central nervous system effects include decreasing cerebral blood flow and metabolism and having an anti-seizure activity. In terms of toxicity, propofol infusion syndrome can result, which consists of metabolic acidosis, lipidemia, arrhythmias, heart failure, and rhabdomyolysis. This is a particular risk with high doses of propofol, prolonged infusion times, or in children. Immune effects have often been highlighted because propofol contains both soybean and egg constituents. But patients with egg or soybean allergies are usually allergic to the protein component of these substances, which is not present in propofol. However, caution should be taken in children with anaphylaxis to these foods, as there is not enough evidence or studies in this population.
Okay, that's very comprehensive answer. Now, can you please list the advantages and disadvantages of propofol when used as a sedative agent for mechanically ventilated patients in ICU?
So the main advantages of propofol are being easily identifiable because of its milky white appearance, having a rapid onset and offset, having no active metabolites, that dose adjustment is not required in moderate renal or hepatic impairment, that it has advantageous pharmacodynamic properties such as anti-emesis, bronchodilation, decreasing cerebral blood flow and metabolic rate for oxygen, decreasing the intracerebral pressure, and having some anticonvulsant activity. Disadvantages include being painful on injection, having no analgesic activity, causing vasodilatation and negative inotropy, and thus causing significant hypotension, causing respiratory depression, toxicity including propofol infusion syndrome, and that there is no antagonist available.
Okay, let's move on to another two class of agents which are commonly used as a sedatives in ICU, mainly the benzodiazepine and dexmedetomidine. Can you please compare and contrast the mechanism of action and pharmacokinetics of midazolam and dexmedetomidine or Presidex?
So midazolam is a benzodiazepine which is commonly used as an anxiolytic, hypnotic, anticonvulsant, and sedative agent. Dexmedetomidine is a highly selective alpha-2 adrenergic agonist which is used for sedation in the ICU. Both of these agents result in sedation through neuronal membrane hyperpolarization, but achieve this via different mechanisms. Midazolam binds to specific GABA-A receptor subunits in neuronal synapses, which is distinct from the GABA binding site. And this enhances GABA binding and increases the opening frequency of chloride ion channels, thus causing membrane hyperpolarization. Midazolam has a synergistic effect when used with other drugs, especially opioids and propofol. Dexmedetomidine, unlike the majority of sedative agents, does not work on GABA receptors, but acts via alpha-2 receptor agonism. This results in the inhibition of adenyl cyclase, which decreases cyclic AMP, resulting in decreased calcium, efflux of potassium through calcium-activated potassium channels, and thus neuronal membrane hyperpolarization. This also reduces the release of noradrenaline. In terms of the pharmaceutical aspects, midazolam is available as a clear solution with a pH of 3.5 in concentrations of 1 mg per ml or 5 mg per ml, and can be given orally, intravenously, intramuscularly, intranasally, and rectally. Dexmedetomidine is available in concentrations of 4 micrograms per ml or 100 micrograms per ml and can only be given as an intravenous infusion. Midazolam is unique in that its structure depends on the surrounding pH. For example, at a pH of 3.5, its diazepine ring is open, making it ionized and thus water-soluble. However, when the environmental pH is greater than 4, this ring closes, making it unionized and therefore lipid-soluble. Therefore, at a physiological pH, about 90% of midazolam is unionized and thus able to cross lipid membranes. In terms of the pharmacokinetics, we can once again think of these drugs in terms of their absorption, distribution, metabolism, and elimination. Absorption. Midazolam has an oral bioavailability of about 40% due to extensive first-pass metabolism and an onset of 1 to 5 minutes when given intravenously. Dexmedetomidine can only be given intravenously due to very high first-pass metabolism and has a slower onset when compared to midazolam of about 15 minutes. A loading dose of 1 microgram per kilogram of dexmedetomidine is generally given, followed by a maintenance dose of 0.2 to 1 micrograms per kilogram per hour. Distribution. Both midazolam and dexmedetomidine are highly protein-bound. Midaz has a volume of distribution of 1 to 1.5 litres per kilogram, while dexmedetomidine is about 118 litres at steady state. Midazolam has the shortest context-sensitive half-time of all the benzodiazepines of 100 minutes after an 8-hour infusion, making it the only one suitable to be given as an infusion. Dexmedetomidine has a significant increase in context-sensitive half-time with prolonged infusions, ranging from 4 minutes after a 10-minute infusion to 250 minutes after an 8-hour infusion. Metabolism. Dexmedetomidine follows zero-order kinetics and undergoes glucuronidation and metabolism by CYP450 in the liver to inactive metabolites. Midazolam is also hepatically metabolized by CYP450's system's 3A4 isoenzyme, but to active metabolites. Midazolam also undergoes some metabolism in the gut. Both midaz and dexmedetomidine have a prolonged duration in patients with significant hepatic impairment, and therefore doses should be adjusted in this population. Elimination. Midazolam has a half-life of 1 to 6 hours, while dexmedetomidine has a rapid distribution half-life of 6 minutes, but a terminal elimination half-life of 2 hours, making it easily titratable as an infusion. Both of these drugs are almost entirely eliminated by biotransformation and then excreted in the urine and a small amount in feces.
Okay, now you mentioned about the pharmacokinetics of dexmedetomidine. Can you please list the effects of dexmedetomidine on the body? In other words, pharmacodynamics of the dexmedetomidine.
So the pharmacodynamic effects of dexmedetomidine can be subdivided based on system. Central nervous system effects include decreased cerebral blood flow and cerebral metabolic requirement of oxygen, sedation, resembling more of a physiological sleep state where patients can be easily roused, analgesia, which can result in opioid-sparing effects, anxiolysis, and hypnosis. Cardiovascular effects include a biphasic blood pressure response with hypertension initially followed by hypotension. Can also cause bradycardia, a reduction in the sympathetic response, and very rarely heart block or sinus arrest. Respiratory effects are minimal, and it does not cause respiratory depression, making it useful as an agent to facilitate weaning and extubation in the ICU population. Other effects include nausea and vomiting, decreased gastric motility and gastric acid secretion, and decreased shivering.
Okay, can you please compare and contrast pharmacokinetics of two other benzodiazepines, that is diazepam and lorazepam?
Both diazepam and lorazepam are benzodiazepines but have varying pharmacokinetic profiles. Once again, we'll talk about the administration and absorption, the distribution, metabolism, and elimination. In terms of the administration or absorption, both diazepam and lorazepam can be given orally, intravenously, and intramuscularly, but diazepam can also be given rectally. Oral and intramuscular lorazepam is well absorbed with a bioavailability of greater than 90%. Oral diazepam is also almost completely absorbed, but its absorption is delayed in the presence of food. Intramuscular diazepam has erratic and variable absorption, therefore is not commonly given via this route. The onset of oral diazepam is shorter compared to lorazepam at about 30 minutes, with lorazepam's onset being about 1 hour for oral dosages. Distribution. Both lorazepam and diazepam are extensively protein bound at greater than 90%. Metabolism. Lorazepam is hepatically metabolized and undergoes extensive conjugation to 3,0-phenolic glucuronide, which is inactive. Diazepam also undergoes hepatic metabolism, but by CYP3A4 and 2C19 to active metabolites, N-desmethyl-diazepam and temazepam. These active metabolites are both further metabolized to oxazepam and mostly eliminated by glucuronidation. Hepatic impairment has minimal effect on the clearance of lorazepam, but significantly impacts the clearance and prolongs the half-life of diazepam, making dose adjustment necessary and caution needed when giving it in patients with liver disease. Elimination. Both diazepam and lorazepam are eliminated in the urine. Lorazepam has a half-life of approximately 14 hours if given parenterally. Diazepam has a rapid distribution half-life, but has a prolonged terminal elimination half-life of up to 48 hours. Furthermore, the active metabolites of diazepam have a half-life of up to 100 hours.
Let's move on to another commonly used sedative agent in ICU. Not that commonly as propofol, but sometimes it gets used more as analgesic, but it does have a sedative properties. That is ketamine. Can you please briefly outline the pharmacokinetics of ketamine?
Ketamine is a dissociative anesthetic and analgesic agent, which is a non-competitive antagonist of NMDA receptors. It is also a weak agonist at opioid receptors and at alpha and beta adrenergic receptors, and is an antagonist at muscarinic receptors and blocks catecholamine reuptake. It is a racemic mixture with the S enantiomer being 2 to 3 times more potent and having less side effects than the R enantiomer. The pharmacokinetics include the administration, distribution, metabolism, and elimination. Administration. Ketamine can be given intravenously, intramuscularly, intranasally, orally, and rectally. It has an onset of 1.5 to 2 minutes intravenously and a duration of 5 to 10 minutes. It has a low oral bioavailability of just 17% due to high first-pass metabolism. Distribution. Ketamine has a volume of distribution of 1 to 3 liters per kilogram and is 30 to 50% bound to proteins. It is highly lipid soluble, which facilitates rapid transfer across the blood-brain barrier. It has a similar context-sensitive half-time to propofol. Metabolism. Ketamine undergoes hepatic metabolism via hydroxylation and N-demethylation into active metabolite norketamine, which is 33% as potent, and which is then conjugated into inactive metabolites. Ketamine has a high extraction ratio, making its clearance susceptible to factors affecting hepatic blood flow. Elimination. Ketamine's distribution half-life is 11 to 16 minutes, and it has an elimination half-life of 2 to 4 hours. Its metabolites are mainly excreted in the urine.
Okay, can you please compare and contrast the cerebrovascular and cardiovascular effects of an induction dose of ketamine and propofol?
Both ketamine and propofol have an induction dose of approximately 2 milligrams per kilogram, but have vastly different cardiovascular and cerebrovascular effects. Cardiovascular effects. Most of ketamine's cardiovascular effects are due to central sympathetic nervous system stimulation. In terms of blood pressure, ketamine causes an increase in blood pressure, whereas propofol results in hypotension. Heart rate. Ketamine causes an increased heart rate, whereas propofol can cause bradycardia and inhibition of the normal barrier reflex. In terms of systemic vascular resistance, ketamine causes increased systemic vascular resistance, while propofol reduces vascular resistance due to profound vasodilation. Contractility. Ketamine has a direct cardiac depressant effect, but this is often masked by its sympathetic stimulation. Propofol also has a direct negative cardiac effect and could cause negative inotropy. In terms of cardiac output, ketamine usually results in increased cardiac output, except in patients who are depleted of catecholamines, such as in the critically ill population. In these cases, the direct negative inotropic action of ketamine may predominate. Propofol results in decreased cardiac output due to decreased heart rate, preload, afterload, and contractility. In terms of myocardial oxygen demand, ketamine increases myocardial oxygen demand, whereas propofol decreases it. Ketamine therefore should be used with caution in patients with ischemic heart disease. In terms of cerebrovascular effect, both propofol and ketamine have differing effects. In terms of cerebral blood flow, ketamine is a vasodilator that increases cerebral blood flow, while propofol decreases it. In terms of the cerebral metabolic rate of oxygen, ketamine increases this, whereas propofol also decreases it. Both propofol and ketamine produce amnesia, but ketamine can cause vivid dreams, hallucinations, and an unpleasant emergence phenomenon. Propofol is much less likely to cause emergence delirium. In terms of analgesia, ketamine has analgesic properties and can result in opioid sparing, whereas propofol has no analgesic activity. And finally, seizure activity. Propofol can cause burst suppression and can therefore be useful in patients with status epilepticus. Ketamine has excitatory activity in the central nervous system. However, there have been reports of anticonvulsive and even neuroprotective properties of ketamine.
Okay, so that brings us to the end of our podcast. Do you have any questions?
Well, I have my customary last question for you, Swapnil.
Okay, I will try my best again as usual.
Okay. Why does the art collector love propofol?
Art collector love propofol. Is it because it's white?
No, because it has an aesthetic quality.
I failed again. Hopefully one day I will get it right.
Yeah, fingers crossed.
Okay, so that's the end of our podcast on sedative agents in ICU. Next time we will be back with another podcast on anticonvulsant agents commonly used in ICU. Till then, goodbye.
Thanks for listening. See you next time.
Bye bye.